everybody. Welcome to the UEA Nursing Podcast. My name is Joe Ellis-Gage, and today we have a group of students who have come in to talk about their experience on their first placement. So we've got 3 adult nursing students with us who are going to just briefly introduce themselves. So who have we got?
Hi, I'm Luke, and I'm a first-year adult nurse.
Great.
I'm Jack. I'm also first-year adult nurse.
And I'm Oli. I'm a first-year adult nursing.
Fantastic. Okay, so I kind of put a call out and said, who wants to come and talk about your experiences on placement? And you guys put your hands up and said, I'd happily come in and have a chat. And what was really good is you've all got really quite different experiences from your first placement. So probably the biggest thing that causes anxiety in year 1 is that first placement. Where am I going to go? Who am I going to see? What am I allowed to do? What am I not allowed to do? All of that kind of stuff. And actually, the majority of the students come out of it with a really positive experience and go, it was all right. I didn't need to be as nervous as I needed to be. So this kind of is an interesting video for anyone to watch, but I imagine it would be particularly interesting for upcoming first years prior to their first placement. And hopefully you'll all learn a little bit from each other about their placements as well. So I'm going to start, even before we get talking about where you were on placement and what you did, just by talking about how you felt before you went on placement. Like, did you feel prepared? Did you feel anxious? Were you pretty chilled about it? How did you all feel?
Yeah, I mean, I've never worked like directly in healthcare, like hands-on before. I'd done just admin in the NHS, so I had an experience, but nothing like this. So I guess I had a bit of an insight into what it could be like, but I was very excited to finally be able to get hands-on after working so
you'd
long.
spent time working within NHS settings,
but
just not doing anything clinical.
Exactly, yeah. So I was very much, looking forward to, I'd seen things and, had an idea of what I could be doing, but, still still very nervous for, especially waiting to find out where our placements would
where
be.
you were going to go.
Yeah.
And then I don't know. Well, let's jump straight to it. You went to an ED.
Yeah.
So how did the nerves go up at that point? You got allocated to ED, or did you settle down?
Yeah. So before I even knew I was going to ED, I kind of said to some of my friends, I don't want to go to ED.
Okay.
Because I want to work there when I'm a registered nurse, and so the plan of being getting it in second or third year, I could do a lot more than when we're in first year with the limited skills we have. And to find out I had ED, at first I was like a bit disappointed, in the sense of I then knew I wouldn't get it unless I picked it as my elective. But then it completely changed, and I was ecstatic and over the moon.
Cool.
Especially with like the level of care I got from the team there. With emails from the day we were told where our placements were, I started getting emails straight away with support. So
yeah. Okay. Great. And how about you guys? How did you feel before you started?
Oh, terrified. Definitely not prepared. I had worked as a HCA in a GP surgery before.
Okay.
So I had a little bit of basic knowledge, how to like blood pressures, manual blood pressure. I knew how to do them. ECGs, knew how to do them.
Okay.
Bloods. So this is stuff I couldn't do on placement, because obviously we hadn't been trained by UEA to do them.
Yeah.
But I'd never done personal care, for example, so that was all new. So, and I think that was something that obviously a lot of people are like humming and hawing about that sort of aspect of caring, but I think it's a really important bit of nursing to know about because, well, that's the basics of it really, isn't it, I think? And, but no, I was completely unprepared.
Yeah, okay. That's interesting. So your background in the GP surgery, you got some clinical stuff there and some skills that everyone else is looking forward to start learning about.
Yeah.
But I guess everyone in the hospital, in the GP setting is relatively well when they come and see you.
Yeah.
And able to care for themselves and do all that sort of stuff.
Yeah, unless sometimes you'll have people come to us and we're like, yeah, you've got a broken arm. We can't really deal with that, or whatever it happens to be. So yeah, but it's basic sort of clinical skills. But then, as I say, you haven't got night shifts in a GP surgery, for example. This was all new. Yeah. So yeah.
Oh, well, I'm going to come back to shift working later and see how you all got on with that in a little while. Yeah, how did you feel?
Extremely terrified and a little bit anxious as well. I thought I try to do as much as preparation possible, like going through what we want to uni lectures and so forth. But I just on the winter break went to the trust itself and actually tried to see where the ward is. I was on a surgical ward, and I went there, introduced myself, and there I've met the staff, and they were very welcoming, and I've been humbled by the experience. So I said, yeah, I think I'm gonna have a very good time.
So it was reassuring going to have a little look in advance.
Absolutely, yeah. Especially since I've never been in a healthcare predicament beforehand.
Yeah, yeah, okay. And did any of you do like particular like preppers in like reading certain things or watching videos on stuff or looking at common conditions that you might see in your area? Did you do any of that?
I did, but I thought I got mistaken with what ward I was on.
Okay,
so
you prepared for the wrong thing.
I prepared for the wrong ward. So that was quite stupid. But when I found out what it was and stuff like that, I did do bits and pieces. I asked them. I sort of did what Oli did. I turned up and introduced myself and had a look around, and I said, "Oh, what sort of medications are like your go-to bread and butter stuff?" So I looked up some of that stuff before I went and had like a little list of 12 or something like that, and roughly what they did. And so I had a little bit of an understanding. But
okay. And you're really well prepared for the other placement if you ever go there.
Well, it's only downstairs from the one I was on. So.
Okay. So we've mentioned you were an ED, you were on a surgical ward, and you were in a community hospital ward setting.
Yeah, rehab ward. So people who've come from hospital, not ready to go home, but just need that little bit more help.
Yeah. Okay. And how did you feel about your allocation?
Fine. Yeah. We chose. I think we were like one of the first years who we've been able to choose our trust, and I chose the community pathway. Coming from that GP thing, I think that's ideally future employers. That's where I'd like to work. So I thought the community would be the better choice for me, but I think we still get an acute setting for me, and then the guys who chose acute get
away community.
Yeah. So.
Okay. Yeah. And so, it depends who's watching this, but people may not know about different things. But you guys as adult nursing students had an option of putting forward your preference for which trust you would spend your time in. Yeah.
Yeah.
And surgical ward, that feel all right for your first placement?
It was incredibly high paced and a large turnover as well. There were patients being discharged like 8 o'clock in the evening, and half an hour later another one would come in, and we need to do admission. And but no, I actually think it was a very good choice that I was in a surgical ward, because I was able to do a lot of procedures. I wasn't even thought capable of doing it, even from the first placement itself, like flushing cannulas and assisted, obviously, on the supervision and administration of medicines, and but even stuff like personal care and mouth care as well, and that was extremely beneficial because that gave me confidence that I can actually do this. Yeah,
and that first placement on building confidence is a big deal, and I think I probably said it to the children's nurses necessarily rather than you guys, but you kind of see a difference in students when they come back from their first placement. Like they're just a bit different. You kind of come in and I've got experience, I've got a bit of confidence.
Yeah.
When we start talking about something, someone will go, "Oh yeah, well on placement I saw this or I saw that." Whereas prior to your first placement, we're desperately trying to prepare you, but it's almost impossible to prepare you for what you're going to see because like you're all going to different places, you're all seeing different patients. So it's that first placement is really good at kind of consolidating everything. And you come back and you go, right, I can do this. And that bit of confidence building is really important. So let's talk about the shifts. How any of you ever worked like shift patterns and long shifts and night shifts and all that stuff?
Yes.
Before, yeah?
No, only in this.
Only in this
ward.
setting.
Yeah.
So just here.
I'd done in hospitality night shifts.
Okay.
But no, never like this.
So not like this. And how did you get on with the shift work? How was it?
was quite different from what I expected. There was a lot of paperwork that was being done during the nighttime. Obviously, a lot of care as well, but probably the sounds was like stuff that really stuck with me.
Okay.
Like all the beeping and all the switching, and even people just turning around in their beds and you watching them, and still need to administrate like even IVs and whatnot, and waking them up for their observations.
Yeah.
And you could see it's not a natural state, but you could still make them comfortable and understandable, and so we can go through all this together.
Yeah. Yeah. The sort of, you guys were nodding along when the sounds bit was mentioned. It, like, there are just
the amount of beeps I heard when I was in bed at home, and I could still hear those bells going.
The call bell,
the call bell, the phones, the pumps that are beeping, and the different machines.
And saying, like, after a while, learning, like, oh, that beep is for that machine. I can't go and do that.
Yeah.
But then, oh, I know what that beep is. I can go and help with that type of thing. You sort of after a while.
You learn to work out what the beeps
without
mean.
Even looking at them.
The occasional emergency one, and everyone legs it and runs, and you know what that one is. Really interesting. And then you think that must be like lots for you guys to learn. Imagine being the patient sat in the middle of that. If you're feeling unwell in the middle of the night, and it is, although the nights are obviously quieter than the days and the wards do settle down a bit, there's still a lot going on.
They don't use the Q word.
Yeah. You get told off for that.
Yeah.
I used to get told off for that all the time. And I'd walk around and go, it doesn't make a difference. But yeah, they do say that. But the volume is lower at night time. But actually, there's still loads going on, isn't there?
No visitors.
No visitors. Yeah. Is that good or bad, having the no visitors?
They for me, I think they it makes it easier because sometimes they'll do bits and bobs for their relative or friend or whatever, and also it's keeping them company, especially the ward where I was. There was a lot of dementia, and seeing that regular familiar face, I think was probably quite a good comfort for those patients.
Whereas, like, for me, it didn't matter.
No.
You know, I think that the other thing as well, whether it be night or day, the only time I really realised it was when I was going out to my car to go home. Yeah. Because unless you were transferring a patient to CT or something, to another ward,
you didn't see outside.
There was no windows.
No.
Unless you were in resus and you were waiting for the air ambulance, then you'd be outside. But other than that, you had no idea what time of day it was.
EDs kind of just continue, don't they? They just
exactly. Sometimes the day would be quieter than night. Sometimes the night would be quieter than day. It really just varied on what had happened the previous shift. It was, kind of how it continued. So
when I was a student nurse, and this is when you get told off for using the Q word, but was my last placement. I do remember that the ED getting empty, like 0 patients for about 20 minutes. Nice. And the nights. It was all the same activities, but it did get quieter at night time. From the moment I registered, I never saw it empty again in all the years I worked there. Yeah. But I do remember that one time. But nowadays, that's just never going to happen.
We had one when I was on a day shift and then a night shift. And on the day shift, I think we come in and because we had like a talk through of what was going on in the department and how many ambulances were waiting, if there were, etc. What the wait times were. And on the day shift, I think there was like 20 ambulances waiting, for spaces, etc. Yeah. Coming in on a night shift, and they're like, there's 4 people in the department. And it was like just a 24-hour difference. And
it's crazy. Yeah, you can't predict what's going to be happening.
And it stayed like that from 7 at night till 3 in the morning.
Wow.
And then all of a sudden it just changed. But just like that, it can so quickly change.
Yeah, you just can't predict it.
The emergency department for a reason. It's just,
Yep. Yeah, and it's the only place that can't shut its doors, can't say they're full. It's you take everything and anything that comes in.
Oh yeah.
So thinking about like some of the things you already explained, how did you get prepared once you got there? Like, how was your induction? How were you kind of orientated to the area? Were you thrown in at the deep end? Did you feel supported?
So I had quite a good experience. So we were supposed to have like an induction day. There was 3 of us first years. Yeah. But unfortunately there was staff sickness, as to be expected in the NHS. So the day was cancelled. And so my first shift, so on the first weekend, it wasn't actually until the Thursday, and I was on a twilight shift, so I was on from 2 p.m. till 2 a.m.
Yeah.
It's my very first shift. So that was a bit of a baptism. But there was
Yeah.
a band 7 who took me in, and she said, "Oh, what do you know?" I said, "Well, I haven't really done
Nothing.
anything." She said, "Okay, I'm going to do a set of obs on you. You're going to do a set of me. Then we're going to go find your first patient."
Okay.
And she supported me through my first patient. And sort of after I'd done that first one, she's like, "Okay, and I want you to go and do one by yourself now."
Yeah.
And just, I was very supported. So most of my shifts as well, I was booked to be on with either my supervisor or assessor, because they'd never had first years
Yeah.
in ED. So they'd planned my shifts around theirs. So 90% of the time I was with my supervisor or assessor, who then knew me. So it made
Made a
my
difference.
nerves a lot better.
Okay. So the planned induction didn't happen.
Yeah,
But you
from
were
then
looked
out,
after.
Yeah.
Yeah. How about you two?
I can't really express enough the gratitude that I have for the clinic education at the trust that I was in.
Yeah.
They were very well prepared, and also they were prepared to make amendments based on my childcare. I have
Okay, yeah.
children as well. And they actually went with me again on my first shift on the ward as well, to make a reintroduction and see if everything is in place, and make them aware I'm a first year student and
Yeah.
whatnot, which was absolutely great. Again, everyone from the ward itself just oozing professionalism as well. Really, really well prepared, and
Yeah.
again, I was a really good
Good.
experience.
Great.
Yeah, so my induction was sort of like you guys, a bit later in.
Yeah.
I think I was 3 shifts in, but my first shift, just started doing obs, and then said, "Oh, do you want to do meds?" I was like, "Okay." And then because I was supernumerary, there was a patient who was struggling to eat, so I sat down and helped them.
Yeah.
But no, again, similar to Ollie, I'm very thankful for the team I had, because
Yeah.
they were top notch, really attentive, and anything I felt like I wanted to give a go, they were happy with.
Yeah.
After maybe being shown it.
Yeah.
or-
Showing you and supervising and all
Yeah.
that. But
but I never was asked to do anything out of my comfort zone.
okay, that's good. That's reassuring, because that's one of the things that students worry.
Yeah.
What if I'm asked to do this? What if I do something wrong? And actually, most areas, you're not left doing something by yourself until you are really, really competent at it. Even something as seemingly basic as something like observations, you start off with a supervisor with you, and once they're happy with you, they'll say, "Yeah, go and do the obs." And then that, you know, and if you do get asked to do something that you aren't confident doing, then if you say that, everyone's fine about it.
So I was able to do take on my badge, the number, the code that you can actually take the BM now.
Oh yeah,
And after that, my supervisor seen it, and what my supervisor would do would devise like a plan during the day and tasks that I could be allocated to do.
Yeah.
But afterwards, she would come in and see everything was being done, and if I missed anything, she would let me know.
Yeah.
Like, this should be in this area and this should be put here. But that gave me confidence that. But she never like overwhelmed me with tasks or anything like that.
yeah. But you get to do stuff to build your confidence. But you got the reassurance that someone's going to check on you, and you know you're going to be looked
and
after.
was nothing
Yeah.
to put the service with the patient in danger or anything like that.
Yeah, and how did you get on with your assessors and supervisors? Because I guess that's another area of anxiety. What if we clash? What if we don't get on?
They were brilliant.
Yeah,
Absolutely brilliant. So my supervisor was a newly qualified, so she'd qualified last year.
yeah,
And my assessor had been doing it, for quite a number of years.
yeah.
So it's nice to have the aspect of a newly qualified. And so she was able to talk me through her experiences of it being so recent, but then also the experience of someone who'd been there for a prolonged period, being at the somewhat the other end of the scale as such. But they were just brilliant. Took me in as one of their own and taught me so much. It was brilliant.
Yeah. I often think your best supervisors are people that have been qualified for a really short amount of time. They're not necessarily always the most confident, but that's great because that shows you a bit of like, oh, it's all right. I haven't got to know everything, and they can remember what being a student is like.
There's, I think, similar really, mine were brilliant. But also the other nurses and the HCAs, really knowledgeable bunch of guys, and they're just like showing you everything. So only one of the nurses I was shadowing, when I was working as a HCA in the GP surgery, she was in placement there, and I taught her how to do bloods.
Oh, really?
So it's just funny how, it then just sort of comes back, and you small world in the old healthcare industry in Norfolk, it seems. But that was nice to see her again. But
yeah,
cool.
And you well looked after by yours? You got on well?
Yeah, no doubt. Both very knowledgeable. One over 20 years of experience, and the other one a bit younger, but same really strong presence. She would walk around, and she was there.
Yeah. Okay.
But no, I'm really grateful for the team that was chosen to direct me towards this experience.
Yeah, great. So then, let's find out a little bit about like what you did, what you were involved in, what you saw, what activities you did. So you're all in different settings, you'll all have different experiences. But what sort of tasks were you doing on a day-to-day basis? What were you allowed to do? What did you have to watch but not take part in?
So I guess for me, being an ED, it's not just one space. There's multiple areas to it, so it kind of depended where you were. So at the beginning of every shift, I would be allocated to whoever I was with, be it my supervisor or assessor generally, and I would go wherever they're stationed to. So if I was in somewhere ambulatory setting where patients were able to walk in and out of, they're a bit more well compared to some other people in other places in the department. In that setting, it'd be more like doing OBS when they're coming in. If they needed a tetanus jab, doing that. So more of the, the less intrusive type things. And I was able to be more hands-on because the patients weren't as
as poorly.
Exactly, yeah. Whereas compared to if I was in resus, where the most ill patients were, it was yes, I was able to do OBS and certain things, but given what they were in for, there was not a lot I could do. It was a lot of observation, but I got to see such a wide range of things. That was, I think, where I learned the most, even though it was more so observing and just being there.
Yeah, and that's both the nature of the urgency of what needed doing. Exactly. They couldn't have time to always say, let's talk you through this. You have to just stand and watch.
Exactly, yeah.
Yeah. Okay. I might ask you about what you saw in resus and what comes up in there in a little while. We might come back to that. So what did you guys go up to?
A lot of personal care, obviously. OBS, dressings, which I found really interesting. Did my first dressing, which was massive, like big wound. And to be honest, my assessor said, that was a bit cruel to make you do that one. But then, like, my CPD day, the next day, I just researched aseptic non-touch technique, what different dressings there are, and why you would choose that one over a different type depending on exudate and stuff like that. And so I would recommend use your CPD days because they are really handy. Did stuff like that. Saw a patient who was really uncomfortable with a catheter problem, and it turns out it was bypassing. So we sort of identified that, and then in the end he ended up having it replaced. But we tried to sort of remove it, and then we couldn't see a reason why he had it in. So we said, let's just try and encourage him to not use that, but it didn't work. So we popped it back in, and it drained off lovely. So that was very satisfying to see that sort of start of the day to the middle of the day or the end of the day when he was a lot more peaceful.
Yeah, and you can see the difference that interventions you have done have made.
Yeah, exactly.
Which is nice.
It was nice. Yeah, very satisfying.
Okay. And Ollie, what sort of tasks did you get up to?
So obviously, started with personal care, mouth care, changing beds, and I was at first really anxious about it because, as I mentioned, I never was in a healthcare situation like this. But I was assisted, and I overcome them, and by the end, I really done them with in a very good manner myself.
Yeah.
So, but I assisted with medication. I've done enemas as well, assisted.
Yeah.
Flushed pigtail drains, flush drains as well, dressings as well, as you mentioned, obviously in a surgical setting. Other type of drains that need to be taken out, catheters as well. So
quite a range.
Quite a big range. Observations, obviously, that was a daily task, which was quite good because you can actually go and check on the patient as well. And because I was supernumerary as well, I could do that task in my own time. And I could really observe and see and do the respirations and everything. And that gave the patient confidence as well. It was not like, damn bad, thank you, ma'am.
And like the benefit of that supernumerary thing, I mean, we should all, as registered nurses, be taking the time to spend with our patients, and that observations is, don't just go in there and stick a SATS probe on their finger and then leave. It's chat to them. Are you comfortable? Can you get you anything? Do you need repositioning? Have you got a drink? All of that sort of stuff. But once the pressures build up, people are busy. So having that supernumerary status is great.
Yeah, that creates a therapeutic relationship between the nurse, yourself, and the HCA that looks after the patient. And the patient start to trust the whole team as a whole. You know that you are able to escalate to your healthcare or to your nurse whatever needs to be done for their healthcare.
And so it sounds like between the three of you, you all did some of the core basics that you're going to learn in your first placement: observations, personal care, that kind of stuff, maybe some dressings, that kind of thing. And then in each of your different areas, some more specialist stuff that relates to wherever you are, which is great. That's kind of how the way it's meant to work. But I guess one of the biggest things you'll have all done is just start doing that relationship building, working out how do you talk to a patient who is acutely confused, who is stressed in an emergency situation and needs some reassurance, and how you approach changes depending on who you've got in front of you.
Absolutely.
Because and something like personal care is a really good example of that. It's a strange task to carry out on someone if they've previously, especially quite recently, been able to care for themselves. And the way you do it is not really the function of it. Doesn't matter. You kind of learn how to do that. But your conversations with the person while you're doing it, in preparation for it, to put them at ease, make a big difference.
Like patients I had very upset with where they were, and that they couldn't do this stuff, and in tears in cases, and you just got to sort of just reassure them that we're not judging them or anything. We just want to help and get them better, and hopefully from my setting, get them home.
And the point of a rehab setting is that they are transitioning back to home.
They just need that little bit more help.
But I guess the flip of it means that if they're in a position to go back home, they fairly recently at some point were fairly able, and actually that can be really frustrating to then not be able to. So that's a challenge to reassure them, build their confidence up.
And there's a bit of confusion as well from the patients sometimes when they probably hear that they're being discharged from hospital, and then they
go to a hospital,
and then they go to a community hospital. There's probably a bit of confusion, a bit of frustration there as well that we sometimes had to deal with. But
and sometimes that process can take longer than they are expecting in that community hospital, because I mean you'll have had the experience of it, but sometimes we can fix the clinical stuff, the immediate bit in the hospital, acute hospital, fairly quickly, but then the recovery can take a lot more time than they were expecting.
When you think about a car crash, something that happens instantly, and then we can patch you up, but then it's going to take 6 months of being in bed or something like that to recover, and then you've always got a rehab from being in bed for 6 months because your muscle strength is all gone.
It takes a long time to get back, and it doesn't end when they leave your ward.
No.
So you could have a patient who starts off spending 4 hours in ED, 8 hours, 12 hours, but time in ED, then goes and spends maybe a week on a surgical ward, and then goes and spends 2 months with you. And all of those stages are really important, but the frustration might come out at your point. Whereas when they're in ED, they're kind of thankful just for being helped.
Yeah. There's one at my point, especially towards the tail end of it. You know, they just want to get home, and that's all we can do is just try and facilitate that.
Understandable.
And I can stress enough the documentation that needs to be done in order to maintain the journey of the patient from admission to ED up until then to final discharge, as you can. And it's never a full discharge because it's still going to go to the GP and onwards.
Yeah.
But it's just mountains of paper currently.
Yeah.
And I don't know, there could be probably areas of improvements there and more communication, dialogue between other healthcare professionals as well.
Yeah, and different organisations. So you were all in different trusts, but your patients don't really identify the trusts as being separate. They don't care. So
It's the NHS.
Yeah. So
They all have the NHS number, but
so some of those challenges are that discharge from one trust into another, then a discharge from your rehab into their GP's care, and how that information is shared.
And talking about the information and the documentation, so I use System 1.
Yeah.
What did you use?
Gosh, I can't
Symphony?
even think. Yeah, but ours was horrible. I really didn't like the hospital one. I think as well because I used to work in GP setting, very used to using System 1. And then to almost feel like you're going a bit backwards. A lot of the staff feel the same way at the hospital.
Yeah. And then you were using primarily paper?
paper.
Yeah.
So that's interesting. There's 3 different methods.
I'm from professional type of view. I don't know where all that would go. I mean, would be very beneficial if that would go into a database, relationship database. That is.
Yeah. Yeah. One of the big challenges currently is there is not a uniformed electronic approach across the NHS. And I don't know how they ever get to it. And some trusts have gone completely electronic. Some trusts have gone are still pretty much all paper. Some are a combination. And then even once you get onto electronic systems, I think in the trust I used to work in, there was something like, I think they said there was 200 different online systems that were used for patient information. So like the system where your x-rays are stored, the system where your blood tests are stored, where your information sharing to external partners is, all of that sort of stuff. There's just so many different systems. Well, you're the nurses of the future, so you'll have to fix it. Maybe
start programming.
by third year, when you have to do your final dissertation project, you need to come up with a problem and do a literature review and a service improvement plan. So maybe you could fix it by the end of your third year.
I'm sure it's been suggested once or twice before.
Yeah, you'll probably get me as a supervisor and I'll say it's a bit much. Rate it in a bit. It's not achievable. So earlier on, you mentioned CPD days. So every week, you get 8 hours a week of allocated time for CPD. So your own learning. What did you do with that time? Because the point of that time is that it's not directed by us. We don't say you must do this, this, or this. It's for what you want to learn, but also for what your supervisor and assessor might direct you to. What sort of things did you do to fill that time?
But other days it would be like, if we had a particularly interesting case and learning, there's a time when we had someone come in with a certain type of heart failure and they had a particularly unique ECG.
Okay.
That cardiology were very interested. He had this patient had a very stereotypical ECG for, I can't remember what it was called, but like cardiology were like, oh, can we have the original copy of that because we're going to use that for research?
Okay.
And just because you'd look at it and you go, oh yeah, that's that condition. So I'd spent a day sort of looking at that,
exploring that a bit more.
Yeah, because sometimes we'd have people come into A&E and resus, and they'd go up to the cath lab or up to cardiology to be waiting for surgery, etc. So looking at that, if I potentially got a placement in there in the future, just having that bit of knowledge, just like depending on what you would see. So I'd also have some days when I hadn't done a particular, or like it'd been things I'd already known about.
Yeah.
So I'd spoken to my supervisor and said, is there any suggestions for what I could do for my CPD this week? And they'd say, oh, have a look. These are some common things that we see. I'd do a bit more research on them, or have a look at side effects of these drugs, etc.
Yeah.
So just it depended on what I'd done that week. It depended on what I was going to do. So
yeah. Okay. And what about you guys?
So obviously the same as Luke. Couple of occasions, but I've also found some interesting cases. But this time was on the ward. Specifically, someone developed an autoimmune encephalitis.
Okay.
So I was really interested in on that occasion to understand how that occurs, what actually happens during it, what causes, if that person would recover, and I really want in depth, just for my knowledge, just to understand treatments and such, if there were. And on another case, specifically, I used to understand the Mental Health Act and DOLS as well.
Yeah.
Because there were some patients on the ward that were under DOLS, and I was a bit conflicted when I met them, and I did, because it was one thing to learn during your lectures.
Yeah.
But it's such a different experience when you actually have hands-on. So that's when you realize, pay more attention during class and try to ask more questions, because they're so beneficial, because you never know when you're actually gonna run into them.
Yeah, yeah. Although, even the best lecturer giving the best thing is only teaching you the theory and the fundamentals behind it until you do it in practice. It never quite consolidates fully. Especially with something complex like when you're looking at things like mental capacity and DOLS and all of that kind of stuff that goes with it.
Complex, I think it needs to be set aside, and a new word needs to be invented for that.
And with your CPD, were you just on a real functional level? Were you on websites? Were you kind of watching videos? Were you reading books? Were you?
I spent a lot of time in the library because I'm living on campus. So yeah, a lot of time in the library. A lot of time on YouTube.
Yeah,
found that to be really handy.
So another question is spoke days or spoke time. So we talk about this whole hub and spoke thing. You're in your main placement as your hub, and then you go on and spoke to see other things. But what's that like in reality? Like, did you do any spoke time elsewhere? Did you have to organise it? Was it kind of facilitated by your supervisor or clinical educator? How did that kind of work?
So I did mine in partnership with the education team at the trust, but because the trust is based at that community hospital, but they run a lot of services obviously outside of there. So one of them was inside one of the acute hospitals, was the RAFT team, the Rapid Assessment and Frailty team.
Okay.
So they're the ones who go and say, oh, patient in bed 5 in A&E at a hospital, they can go home, and 1-6 they need to go to a rehab ward. And so seeing where the patients that I was dealing with came from.
Yeah.
And another side of it was I went to the hospice in Norwich and saw what might happen to patients who don't make it to us, or maybe do make it to us, but then for some reason deteriorate further. And then I did, I don't know, loads of other places, lots of different types of rehab that were just run in the community for people with pulmonary rehab, COPD and stuff like that rehab. And then also I did a more of a mental health, like in a respite centre, where more for the family, I think, who are looking after someone for their respite, but that was quite interesting.
But you basically made the most of the fact you were in a trust that had lots of different teams doing loads of different stuff.
Yeah, and there's loads of different stuff, and I just went onto their website and it said, this is the services we offer, and these are like the numbers for people who want to refer over to them. I just started ringing people up, saying, "Oh, can I come in?" and stuff like that, and got a list of them who I wanted. And
if you're proactive, then you get the opportunities, I suppose. Yeah,
it was good. It was, and I would recommend people doing that. Even if maybe their first placement they might want to just stick where they are and get used to it. Yeah, but definitely second and onwards, I would definitely recommend people doing that.
Get out of your comfort zone.
Yeah, and you said you went on a spoke day in theatres, is that right?
Absolutely correct. To see a patient coming in and getting ready and do all this checklist before getting into the theatre preparation, when they were supposed just to stay on sips of water and stop food and nil by mouth and make sure everything was on the board, and that's being presented in the handover as well. Some medication need to be stopped as well because of the procedure they will be undertake.
Yeah.
But also I was able to see from the theater side how they would come in and see everything was get ready. The patient was actually the patient that needs to be taken away, where the operation needs to be was like marked. Making sure all those steps from the checklist was ensured. But I'll be honest, the place where I actually found myself was in the theater environment. Coming in, the patient being laid on the bed, the anesthesiologist would take over and would start speaking about the procedure that they would be doing, and give the drugs, and you can see them dozing off and making sure everything is prepared, and then putting them in. And but before that, very important, before every operation, there would be with everyone involved, they would present themselves, and they would say what their skill would be during the, and also met their first year ODP, and she was very nice to help me, and just get around
yourself with the
environment. But also the doctor during the procedures as well that I've seen there was kind enough to tell another personnel there, to healthcare personnel there, to bring me a chair so I can sit over and invite me, and wasn't really talkative, but I could have a very good overview, and then to see the recovery of the patient, so how they would wake up, how they will go over in the chamber that they would basically be prepared to go on the ward itself. That was very humbling, to be fair, because you take someone's life, you'll be responsible for them on that time, and everyone was so careful with everything, and so professional in terms of up until where you can go, but never rude. But you can feel them.
So I suppose in theatres you're kind of you're learning like some of the clinical things. You're looking at what's happening, you're learning all that, but you're also learning about the process that the patient takes.
And also after the surgeon finishes the procedure, would go to the ward itself.
Follow up,
and also I was able to see when operation would take longer than anticipated, and why, and they would call another professional to help with that operation as well, which was, so everyone there doesn't have any ego per se. They're there just for the patient's well-being.
So having a surgeon that says, I need some help here.
Yes.
Yeah. And that's a really important thing to learn, because if you see surgeons who are saying, I need help, then that's reassuring that as student nurses, you can say, I need some help when you're out of your depth, which will happen.
That's why I was so humbled by the whole experience. But no, everyone was like, look, if you want to go have a drink or something, no one would bat an eye. Like, you're here just to observe and to take as much as possible. So I'll be making sure I'll be making more spokes into theatres.
Yeah, great. And Luke, did you do any spokes elsewhere or
didn't,
not?
Actually.
Well, I thought you might say that.
So I guess part of the reason being is that they've never had first years. So it's very much for second and third years. And even on then, the ones that I would have been interested in, I think it was for RRT, and there was another one as well, but on there it already said only available for third years. So already the ones that I was going to potentially be interested in, I couldn't do.
Some of the stuff that you see in ED is more complex, so the teams they link to are often a bit more complex.
Exactly, but the fact that ED is so vast anyway, I was not in the same place in 2 days in a row. And the fact that when things were happening and going wrong for a patient potentially, other people were called in. And like you said about the ODPs, I met an amazing ODP where this patient was critically unwell, and he took the time to show me so much stuff. And I just really felt really taken in, and it this person just took their time out to show me these medications they're going to be using and instruments, and it's brilliant.
Yeah, so I suppose like your setting, Jack, was like, I'm in a place where I'm in quite a structured kind of ward, but I've got loads of opportunities around me. ED's almost like stand still for a little while, and you'll have some spoke opportunities that will come to you.
Exactly. I didn't need to make the spokes because it's almost they were virtually happening for me.
Different specialties coming in, different professions,
Absolutely.
all of that all day long. Yeah. Okay, that's interesting. So then, earlier on, you talked about being in resus, and people will generally kind of find that quite interesting. You know, that's the sort of thing as students, they kind of go, "Oh, that's interesting. What did you see?" So, what did you see, and what did you kind of learn from that sort of setting?
Yeah, so in resus, I was very much an extra person. I really was truly supernumerary.
Yeah.
But I'm the sort of person that I really enjoy the thrill of things going on.
Yeah.
Like major trauma, etc. That's really, it's horrible for the patient. It's the patient's worst day, no matter where you are in ED.
Yeah.
But I really work well under pressure and in high stress environments.
So it suited you.
Absolutely, and especially there are some days in resus where it was a bit quieter than other days, and we had one particularly bad day where we had 3 air ambulances in a row, and that was a day when I was in there, and 2 of them weren't as major as first thought.
Yeah.
But one of them,
was
very So initially, what happens when air ambulance is coming in, consult, because you don't always have the consultant in resus because quite often they're spread out throughout the department.
Yeah.
But when they are there, the seniors are alerted, and this just came in as a gentleman with a chest training by the air ambulance. Had fallen off their bike. That's all we had. So they didn't call it as major trauma to start with.
Yeah.
They were going to do an assessment first, and when they started doing their assessment, that's when they realised
there's more to this.
Absolutely, and they needed more help. So that's when the consultant said to the lead nurse to put out a trauma call. So the RRT team come in. So they come in so if the patient needs intubating, which they didn't, but they did later on. But at that time, and other specialties being called in. The patient had a major hemorrhage as well, so having to go get blood for them.
Okay.
So because there were so many people, and in that, even though it's in resus and the bays are much bigger than anywhere else.
Yeah. Still busy.
Quickly fills up.
Yeah. You get a lot of people out when those calls go out.
Yeah. So I was asked if I could step out. Of course. But the nurse said no. Luke's staying in there. I want him to watch this through. So I was very fortunate that they were advocating for me, and so to be able to stand at the back and watch all of this unfold, just seeing so much stuff, it was organised chaos.
Yeah,
it was really quite beautiful to see, and just seeing all these people working in harmony, someone putting an arterial line in, catheter going, all this stuff happening at the same time.
Yeah, everyone knowing what their role is.
Absolutely, and it was beautiful to see.
Yeah, when it goes well and you get something, and often something like a trauma call tends to go well because it's so structured. Everyone comes in, someone's in charge, delegating the tasks out.
Exactly,
yeah.
And so quite a lot of the time, in A&E, whenever someone goes to CT, you have to go with them. And it's normally, just one of the nurses. But in this case, that was 2 doctors, there was 10 of us crammed into the CT room because they needed to know there and then. And they had to go off to theatre and such. And I think sadly they did later pass away, but sort of we did our bit. They stabilised them and got them to where they needed to be. But it was really something quite beautiful to see in such a harrowing situation. Yeah, to see all these professionals working dependently together. Yeah, at times not saying a whole lot, but everyone knew their position and what to do and when.
Yeah. Oh, great. That's really interesting. So, I guess we've kind of heard a lot about your experiences on placement. What you did to prepare, what you've seen, what you've experienced, what you've done. So I guess my final question is kind of like, what would sort of words of wisdom do you have for student nurses who are preparing for their first placement? Or I guess they don't necessarily need to be their first placement, but they might be a different placement and they're going into ED or into a rehab or into a surgical ward. What would you say to them to reassure them?
I would definitely tell them to pay a lot of attention during their NPS and manual handling, and ask lots of stupid questions because they would never know in what predicament they can present.
Yeah.
There's too many of them to mention currently. Also, anatomy lessons. Open your ears so you can understand and how even basic stuff like osmosis and stuff like that. Just listen, because you'll understand then how IV worked, and also pharmacology as much as you can. Abbreviations. Try to make yourself comfortable with them, and ask your lecturers questions until they don't want to listen to you.
Not possible, but always listen. But sometimes we teach you stuff, and you might at the end of that session go, "Okay, well, fine," but I don't see where that fits in yet. Eventually, it probably will fit in somewhere, and it will be relevant. Yeah.
I think knowing what QDS, TDS, BD, and all these things helped. I would probably say engage with your team that you're with, because like them or low them, you're going to be working with them for 8 weeks or however long your placement is. And in my case, say brilliant bunch of people. Engage with them, and don't be afraid to. What sort of Oli was saying, don't be afraid to ask a stupid question.
Yes,
because you'd rather ask the question, have a bit of knowledge of what you're doing, as opposed to not knowing what you're doing, which is when mistakes can happen.
Yeah. And people would rather answer a question that sounds a bit daft than you not ask it and them have to come and help clear up them after the mistake that you've made or something because you've misunderstood something.
And document.
Yes.
Document everything.
Good.
Yeah, I'd say you'll get out of it as much as you put in.
Yeah.
You know, you put yourself forward to things and you'll get to do things you wouldn't even imagine. I'd say stand up for yourself.
Yeah.
And don't be afraid to show your emotions. You know, you're going to see things that will make you feel things that you've not felt before.
Yeah.
You'll see things you've not seen. And, you know, don't forget that, you know, everyone is on the course doing the same as you. Talk to them, you know, keep in touch.
Yeah.
8 weeks might not seem like a long time, but 8 weeks without seeing, you know, your friends, your colleagues.
Yeah,
just
keep
keep in
a while.
touch.
Yeah. And there is the support out there from lecturers, fellow students, educators and stuff out in practice. But often you've got to go and ask for it.
Yeah.
Because people don't know if you need that support unless you're there speaking up for it.
I'll probably just have one more thing to mention. Pair documentation.
Okay.
Be prepared for the unpreparedness out there. Just make sure you understand it, and you can ask questions when the opportunity arises, and make sure you tell your supervisors and advisors and clinical education team and whoever, lecturers, just tell them you need time to do it, so you can get at the end of the placement with it completed, and you'll get that final message of you've completed and you've passed it. Otherwise, a lot of unnecessary headaches for everyone involved.
Yeah, it's a good point, because we always kind of say to the start, you know, it's your document, you're responsible for getting it completed, but it can be quite hard, especially as a first year, to say to someone, we do actually need to do this, and I do need to book in a time for my final interview or my midpoint interview, and it feels like you're causing a bit of a pest. Yeah. But you're far more trouble if you get to the end of the placement and you haven't done it.
True.
Yeah. And then everyone's trying to ask out and find out why.
Yeah.
And your first placement's tough because you're learning what pages need completing, you know, what proficiencies need to be done, whereas at least by placement 2 and then next year you're following a similar system. Yeah. Okay, cool. Well, I think we've learned a lot from your various experiences. So thank you very much for coming in to chat about it.
Thank you for having us.
All right. Thanks for watching. Hopefully you've found this interesting and informative. If you liked it, hit the like button. You can share it with other people who might find it interesting, and you can add comments in the chat below if you've got any particular questions. And you can subscribe to the channel so you don't miss out on future episodes. So thanks for watching, and thanks everyone coming in.
Thank you.
Thank you.
Cheers.
Cool.
Thanks for having us.